Hello and welcome to Lessons from Ground Zero, a live webcast about the coronavirus pandemic presented by the Catholic Health Association. Thank you for joining us. My name is Nadine and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the bottom of your screen, you will see the Q&A option. To send a question, click on the Q&A button and type your text. When finished, click the Send button. All questions that you submit are only seen by today's presenters. We are joined today by Sister Mary Haddad, President and Chief Executive Officer of the Catholic Health Association, and our moderator, Lisa Smith, Vice President of Advocacy and Public Policy for the Catholic Health Association. At this time, I'd like to turn the presentation over to Sister Mary for opening remarks.
Thank you so much. Good afternoon, and thank you for participating in this special presentation from the Catholic Health Association of the United States on the current coronavirus pandemic, Lessons from Ground Zero. As you know, the pandemic continues to spread throughout the nation with nearly 50,000 confirmed COVID-19 cases and 600 deaths as of March 24th. Catholic healthcare providers are working quickly and tirelessly to treat those affected by COVID-19 and attempting to contain the spread of the pandemic, often with very little of the information and resources they need to do so. We hope today's presentation and discussion will help those of you working in the field to understand a little better how one of our ministry's health systems has been responding to the call in one of the worst affected areas of our country, Washington State. Before I introduce Dr. Meadows, let us offer a prayer for everyone suffering from the coronavirus. I'll start with an excerpt from Psalm 91. You shall not fear the terror of the night, nor the arrow that flies by day, nor the pestilence that roams in darkness, nor the plague that ravages at noon. Merciful God, hear our fervent prayer for all who suffer from the coronavirus. May those who are infected receive the proper treatment and the comfort of your healing presence. May their caregivers, families, and neighbors be shielded from the onslaught of the virus. Give solace to those who grieve the loss of loved ones. Protect and guide those who strive to find a cure, that their work may conquer the disease and restore communities to wholeness and health. Help us to rise above fear. We ask all this through the intercession of Our Lady of Lourdes, and in the name of your Son, Jesus, and the Holy Spirit, now and forever. Amen. We are so pleased to be joined today by Dr. Rhonda Medows, President of Population Health at Providence Health System, the nation's second largest nonprofit health system spanning 7 states, including Washington. In addition to her work at Providence, Dr. Meadows also serves on the CHA Board of Trustees and is chair of CHA's Advocacy and Public Policy Committee. We have long valued Dr. Meadows' expertise in the healthcare sector, particularly her interest in how we can better address the complexities of special needs populations. Thank you, Dr. Meadows, for taking the time to be with us today. Our discussion will be moderated by Lisa Smith, CHA's Vice President of Advocacy and Public Policy, who will also help field your questions. So with that, let me turn it over to you now, Dr. Meadows.
I wanted to first start by saying I wanted to thank you for letting me share some of our experiences, our strategy, and some lessons learned through the Providence Health and Services, as well as our St. Joseph community. I also wanted to let you know that what I'm about to share with you is the hard work of many, many, many talented people and committed people. And I'm going to share with you my observations only, but know that there are a whole lot of really smart and dedicated people pulling in the same direction as we work through this pandemic. For us, it's been a very hard and long 2 months since the first case of coronavirus was confirmed in a 30-year-old man who had traveled to Wuhan January 21st. If you can believe, it's only been 2 months. The first death occurred here in Washington State as well, a 50-year-old man with risk factors who lived in Everett. And then the nursing home tragedies in the Kirkland neighborhood, not far from where I'm sitting right now today. All that being said, I can probably share with you a couple of things that we've kind of done and experienced and have learned that hopefully will help inform your own strategies and your own approach. I will tell you that when the first case was confirmed, we all jumped in, all in at the same time. Back then, it was still being labeled an epidemic, and we knew that we already had some issues and concerns with public health, being able to do disease surveillance, because if you remember back then, we had a lot of difficulty with getting test kits, actually doing the lab part of the surveillance that is so important in actually helping us understand what our baseline was and the rapidity of which it was changing. We already knew that there was no treatments, no antivirals or vaccines, and so that meant that we had to focus on basically using our clinical skills and assessment and having the operations needed to both screen, to both diagnose and to treat. You may think that at first our focus was solely on hospitals and EDs, and I would like to let you know that those were prime areas of focus, but we also included in early on all of our clinicians across all care settings. We also began adding in our operators, our IS, our shared service support agencies, because there's no way we could possibly do this unless we all, again, leaned in together. Initially, our response was focusing on making sure that we understood our capacity, doing our surge planning, doing a supply survey and assessment, understanding where our supply chain was, and testing. While that was going on simultaneously, our clinicians, healthcare providers, and frontline folks were all having their information and skills updated, focused on COVID itself, what we knew about the virus, its spread, as well as the high-risk or higher-risk populations we needed to look out for. In addition to all of the work focusing on hospitals, emergency rooms, there was also the focus inpatient on our understanding of what we had capacity-wise for ICUs and ventilators. Given what we knew about the higher-risk populations, the propensity for developing pneumonia, acute respiratory distress syndrome, and death, we knew we needed to focus on making sure that the acute and more urgent care needs were addressed in a way that we could actually be prepared for a potential surge. The Physician Enterprises group actually led the charge in getting all of our 23,000 employed, affiliated, and foundation clinicians up to speed, keeping them connected, as well as building out their capacity and assessing their ability to, again, address surge. In addition to the hospitals and physicians, we had ambulatory care settings under a great leader focused on perhaps we could use the express care clinics, urgent care clinics, and a variety of other sites, so that some of the volume of patients that came in, we were hoping we could actually direct to the ambulatory side of things. We soon learned that because of limitations in the actual test kits and then later limitations in protective gear, mask, etc., that we would have to actually kind of pivot a little bit later on and actually change from focusing on getting people into express care clinics and instead get them focused on using express care virtual healthcare, moving to the digital world. There's probably no time like now where telehealth, digital health, the use of chat box and telephonic support has been more important, particularly after social distancing and teleworking became more and more a part of our everyday lexicon and practices. So physicians, ambulatory care settings, and then the real hot spots, right? The nursing homes, assisted living, home health services, hospice, any kind of residential type facility where we knew closest to people would be in place meant that we needed to focus really, really hard in making sure that not only were the staff trained up, but that also patients' families knew and understood the importance of actual the hand washing, the preventive measures, the need for taking hygiene and disinfecting to a whole nother level. And then later on came the social distancing. that you've seen and probably have read about in the paper. In addition to physicians, ambulatory nursing home care, I would be remiss not to mention that our community health partners, our mission leaders, and our population health leaders began reaching out beyond the confines of Providence St. Joseph Health, our facilities, and our clinical offices to actually reach out to community partners and to more marginalized or at-risk populations, including those people who in our community who are homeless, have difficulty getting access to services, and in at times such as ours, having difficulty getting services that actually allow them to survive, like food and shelter. As I've said, virtual care and telehealth services has taken off and skyrocketed. I think initially we thought of it as an adjunct to the care we could provide in person with our doctors, nurses, clinics, and hospitals. It has begun to play a huge role and will only grow bigger. As we've gone more into the social distancing and telework type situations, we've actually depended upon it as a way to more directly connect with each other, but also as a way to reach out to our known patient population, as well as members of the public seeking care, advice, or information. You might think this is a whole lot of different groups all acting and moving at the same time, and it is, but I think one of the great lessons learned was how to connect via command centers, whether they be clinically focused, operationally focused, and then later financially focused, but to also include on a regular basis twice-a-day huddles that, again, extend to the clinical teams and clinicians, but also include operators, finance, population health, community health, government affairs. So it gives us an opportunity to connect with each other twice a day, to hear the updates, to hear what's progressing, and to also realize where there are times and places and we can help each other out. And that's really, really important. I'm going to say that at some point where we thought we could expand our ambulatory and outpatient service areas as a place to get screening, we were focusing on doing things like setting up tents on site, anticipating the needs of patients, whether they were minimally ill, worried well, or actually acutely ill. If they came through, we could actually kind of assess them, triage them, and treat them appropriately. So we started setting up tents and then quickly realized the importance of IS, operation services, and a whole bunch of other folks, and how we actually get those ready. We set up DriveUp Testing as well. The DriveUp Testing actually is a little bit limited by the number of test kits, swabs, and PPE for the people doing the test themselves. To date, we have about 59 DriveUp test centers. We have on-site tents that are set up as well. When test kits are available, they can be available. Telehealth is now extended out to, as of today, 7,000 physicians for their use in connecting with their patients. A chat box was created and set up for online patient evaluation so they could do a self-assessment using the knowledge that we have. And then I believe it's also been supplemented further with FAQs for the most frequently asked questions and with simple, straightforward answers to kind of help address knowledge and basically beat back fear. And so those are the places where we had pivots going along the way. As things and supplies got tighter and tighter, we probably pivoted before the announcements this week, advising that testing be focused on patients who were acutely ill in hospitals, particularly those who we believe clinically appear to have coronavirus, as well as those who had COVID-confirmed cases. We were focusing on patient populations at higher risk, adults. I know we keep saying that it's the older people. I think I'm beginning to fit into that category. But I think, quite honestly, if you look at the data, some of the risk starts with people even in their 50s who have hypertension, heart disease, lung disease, right? COPD, asthma. The risk of more significant illness, as well as the pneumonia, the acute respiratory distress syndrome, and death increases tremendously, going from 65 into people's 85 to 90 range. We started focusing the limited tests we had on the people who are acutely ill in the hospital setting. And we also were focusing on frontline healthcare workers who were taking care of them. You probably have seen and heard us asking in every available venue that we could find assistance and help with actually getting the personal protective equipment, PPE, the regular face masks, the surgical masks, the face shields, and the N95 masks that we need for the people who are acutely ill and getting aerosolized related treatments in the hospital. The limitations of those supplies, those basic supplies, has greatly changed how we approach this. We've moved from trying to do testing for surveillance to testing for diagnosis and for information about immediate contacts with people who we believe have coronavirus. We've done a great deal of work trying to make sure that the frontline healthcare workers are also tested quickly and appropriately during exposure and during their work, because we need to make sure that we are protecting them and understanding transmission with the equipment that we're giving them and as they go forward. I am trying to cover a lot of ground in a little bit of time because I want to make sure that I leave enough time for questions and for some idea sharing and some thoughts. But I want to make sure that I kind of emphasize, probably for the 85th time, the importance of having that protective equipment, those masks, as fast as possible, and to keep them coming in. We found that even despite our efforts of supply chain early on, putting out requests, inquiries, and procurement orders through government programs, through domestic suppliers, and international suppliers, we found ourselves quickly competing with everybody else, not only in our own country, but in other countries as well, and all kinds of folks trying to get the same type of supplies fast. With the outbreak in Washington kind of starting, being the starting ground and then spreading, we, of course, Providence are accountable and responsible for 7 states. So it wasn't simply Washington, which was enough, honestly, but we also see the spread in Oregon, California, some places in Texas. Montana and Alaska appear to be minimally impacted at this point. But that's the kind of focus that we had. If I can add, in addition to trying to get supply chain to get things in, we have asked professionals from all walks of life, you can imagine, to donate PPE and mask supplies. That includes dentists, pharmacists, we've asked veterinarians, we've asked everybody who we can think of. I think we, along with every other health system on this coast, brought up as many construction masks as possible because they were the closest thing to what we needed to protect our frontline workers and to use for some protection against people who were acutely ill. When that wasn't even still sufficient to get the amount of PPE and mask supplies, a group of people here with great big hearts and souls and strength of will started actually making homemade masks and face shields. I'm happy to tell you that what is now the 100 million mask campaign has moved from the kitchen table or the conference table with people individually trying their hardest to do this to actually having some companies step forward to manufacture them for us, including, I believe it's Nordstrom and a manufacturing company that works with garments. There are a couple of entities that are now stepping forward. But I will tell you what, the unsung heroes in my mind and in my view are those people who actually sat at the conference table, used a pattern to cut out and make face shields to protect frontline workers so that they could continue doing their work. And they wore those along with surgical masks. We began literally rationing N95 masks from the beginning because we knew that we did not have sufficient quantities to give them to everybody. We focused on those who were going to be exposed to aerosolized spread by having direct contact with sick patients. I've spoken a lot about what we have done on the clinical side, on the hospital side, ambulatory physicians, but I also want to make sure that you know that alongside them, for operational leadership teams also rowing in the same direction to support this effort. So the hospital and ambulatory surgical center operational teams ceased elective surgeries and procedures, but you don't just push a button to do that, right? You have to let people know that they're going to be rescheduled, that their surgeries are going to be delayed. And so there's a lot of revamping and pivoting to focus in on the pandemic population itself, but also gently and respectfully ramping down our everyday elective surgeries and procedures. The human resources team and partners have been focused on workforce, both the clinical workforce as well as the non-clinical workforce. We, like most of you, are teleworking. Most of our states have stay-at-home orders. Some come with criminal penalties and jail time to make sure that we are very clear on the seriousness on this. We have also already been providing mental health services, going beyond the usual EAP, but to also online and telephonic behavioral health and support during incredibly stressful times. There's a whole host of caregiver support services that have been ramped up by the Human Capital and Resources team that includes everything from on-site childcare for those healthcare workers who we need to continue to work with us on the front line, to actually also providing extended sick leave, days off, that kind of thing, and making sure that we are taking care of the very people who we need to take care of, the people in our community. Our finance teams initially were focused on moving funds around to actually finance the work and the rev up and the investment that we needed, and have kind of shifted to tracking the cost and spending, as well as figuring out how to do the billing for COVID-related testing, care, hospital stays, etc. They are also tracking, along with most of you, the federal funding, and sit with you with their fingers crossed on this third but not final federal stimulus bill. Payer contracting team as well. I know you don't think about this as being part of the response, but part of actually being able to do what we do is making sure that we are financially sustainable through it. So while the clinical teams are taking care of human beings and lives, the payer contracting team is making sure that they're taking care of the relationship with human beings that work in payers, health insurers, which means that any time that we talked about what we need to delay billing because we need to get our stuff together and figure out what we're actually going to do and how we're going to do it, we have to make sure that our partners, our health insurers, our health plans are with us on that. And we've had no difficulties, no pushback in anything that we've asked them to date. And that is great. And then probably the other folks that are Lisa's partners and that have actually done a tremendous job in representing the needs of both our communities and our health systems, government affairs. Going to town and going to bat with both the efforts for ground roots advocacy on behalf of health and human services in general, but hospital and healthcare providers more specifically. We anxiously await the final result of the third stimulus bill and are doing the work of trying to figure out what should go into the fourth. So I've covered a tremendous amount of ground, and I'm seriously hoping that you have heard me throughout this. I'm assuming someone would tell me if the sound had dropped off. But I want to thank you for letting me share that with you. Right now, today, we are approaching 62,000 cases in the United States with a heartbreaking 859 deaths. Of the four top states in terms of the number of confirmed cases of the coronavirus, New York, New Jersey, California, and Washington, Providence is in two of these, Washington and California. And in Washington in particular, where it all started, we are today at 2,662 cases and growing. We are watching every day the counts, both those that we clinically believe are probably infected and appear that way, and the ones that we have confirmed through testing. And the uptick is still occurring, just steadily going up. I'm hoping that the social distancing, the teleworking, the people, the stay-at-home orders will kick in, but we know that typically that takes about 2 weeks before we actually see the impact of it, before we could possibly have reached a peak and start seeing a gradual decline. As I've told people on my team, if this follows anywhere near the pattern of some of the earlier things like swine flu and things along that line, we have to prepare for not only this first wave, this surge, but then to be aware through surveillance whether or not there's going to be a second. So I'm going to pause there and give your ears a rest, but I'll open it up for questions and comments.
Great. Thank you very much, Dr. Meadows. We do have a number of questions that we have received, and I'm also going to let folks know we also have Allison Orris, who's a counsel with Manat, Phillips, and Phillips on the line with us as well. So Dr. Meadows may kick some questions over to her as well. So I wanted to make sure you all were aware of Allison. Our first question is, how are you handling workforce management, scheduling shifts, helping workers with childcare issues, things of that nature?
So as I mentioned, the human resources and talent management teams have actually already put out their proactive communications to all of our employees, both clinical and non-clinical, extending their sick leave, their time out of office. Everybody is teleworking, and the IS team has done a great job of actually getting the equipment and the setups available to people. We do have childcare offered. It's community specific because it's close to where the people actually live and work. We can get you the information that describes each of those programs, and that's, I think, something that might be of help. We can also talk to you about the support that we are giving to those caregivers within our midst that actually we're learning some new things about. We've discovered a few that despite what we see and know every day have either issues with being homeless, have issues with being a single parent, with issues of having difficulty in getting the resources that they personally need, and so we are propping them up. We are supporting them and getting what they need. And when we are able to do that really, really well, they are able to then help with the effort going forward. We have sent out a tremendous amount of information, educating people again and again and again about coronavirus, how it's spread, how to take care of yourself, and prevention matters. We have educational videos, conferences, webinars that are running frequently at the local and community level with our caregivers, including the clinicians, to basically show them how to use PPE equipment, mask protocols, how to report, how to express concerns. And, of course, the mental health support that I mentioned also.
Great. Thank you very much, Dr. Meadows. Our next question is, did you find yourselves having to ration ventilators and if so, based on what criteria or necessary triage in making those decisions are set into place to if and when there are not enough to care for all?
We have not had to ration ventilators yet. We basically know where they all are, what state they are in, whether they are ready. We have projections that a lot of very talented people have been building upon and improving upon that tell us that we are in need of 3 times more ventilators than we have. And that's anticipating the patient volumes to increase as they are now. There are teams, and one team in particular that is comprised of our ethicists, mission leaders, as well as clinicians that are working on a discernment process now to decide if there's a process we can put in place that can be used consistently. Should that come to pass, should we actually come to the place where we don't have enough ventilators, our patient volumes are overloading the ICUs and our ability to address them. Those are discussions that are happening now, but none of those decisions have had to be made yet. We have supply chain and a host of other people out also seeking ventilators from every which way that you can think. So not only within our hospitals, but any kind of ventilator-type apparatus that is in their ASCs, the ambulatory surgical centers. And we've gone so far to reach out to a more unusual partner, the American Veterinarian Medicine Association of America is a national organization that is similar to the AMA. And the veterinarians have ventilators for large animals that are actually made by the same manufacturers that make ventilators for people. That organization has generously reached out to all of their member chapters, veterinary schools, and put out a call to veterinarians to also catalog what ventilators they have, which ones they can donate and loan, et cetera. And the responses have come in from literally almost every state at this point. Even still, we still need more ventilators manufactured and made available. We've gotten suggestions about contacting China about the ventilators they have. We have difficulty getting things from international sources right now.
Thank you very much, Dr. Meadows. Our next question is asking, what is your thought on assigning masks to providers and reuse during the day?
I think we are assigned based on what they are actually doing. We have already set up and in place a program that actually sanitizes the mask. So when they've been used, they can actually be put into a bin that actually goes through sanitation before it comes back for reuse. And that is not our first choice, but that is the realistic choice while we have shortages.
And we have a follow-up question on that. I'm curious about homemade masks. How effective are they? Is there any specific guidelines for making them?
So if you were to go on the 100 million mask link, it'll actually show you how we came up with the design and how we tested them. We actually did prototypes and did an evaluation of them before we started producing them more and before we gave the prototype and plan along with the required materials list to the manufacturers. We were purposely using surgical grade equipment, like cloth and materials for the masks themselves. Believe it or not, the face masks themselves, it's plastic. And so we had to do, again, prototype testing of different designs to make sure that they would cover the face and protect the wearer. Those are, again, tools that we would use, resources that we could use, not in the room of a patient who is receiving aerosolized treatment and care, but we can use it for other places outside of that space. We would love to be able to have everybody with an N95 mask. We don't know that that's necessarily necessary, but that would be the highest level of protection that we could provide if we could do that. It is simply not possible today with the shortages.
Thank you. Our next question is, we do not have adequate tests and are prioritizing critically ill patients and sick employees. Also, tests are taking 5 to 10 days for results to be reported. Any thoughts on what we could do differently from your experience?
So for us, we are still short on tests. We prioritize, just as you said, and ours are taking 3 to 4 days to get results. You know, the clinicians are actually treating the patients supportively because there's no known treatment, right, or vaccine. The tests are actually an adjunct. They don't stop us from treating the patients at this point. I know that there is talk about the 45-minute test. How quickly that can become available, I don't know. I'll be quite honest with you. I think that in addition to the delays in getting the test results, we are still experiencing delays in getting not only the test kits, but the swabs, and some labs that actually have to process the test in order for us to get results are running short on reagents. So I don't have an answer for how to resolve it. I'm simply telling you what we have observed and see at this point. I know that there are also some home test kits that are being promoted. I'm going to be a little tiny bit skeptical here, only in that We already know that we can get false negatives if a trained clinician doesn't do the nasal swab, the specimen acquisition correct. I'm a little bit concerned that the home test kits, an individual, the average person, may not feel comfortable doing the deepness of the swabbing to get a sample that will be adequate. I don't want people to get the impression that a false negative is something that gives them a free pass.
Thank you, Dr. Meadows. The next question is, what approach is your hospital system currently taking for patients that are PUI, that are unable to return home and need skilled nursing facility placement? Same question for COVID-19 positive hospital patients needing skilled nursing facility placement.
So the patients that are COVID positive and the ones that are PUI with test pending or test about to be done type thing, for the most part, if there are beds available, they stay where they are until they test negative and move out. At some point, we're not going to have enough capacity, enough beds to do that. So there are multiple work streams, both at the regional or state level, as well as at the system level, working on looking at where we can actually build out space. There is a physician, Dr. Mill, who is doing a great job, and he's already identified in every one of our regions the physical spaces that could be adapted for both two types of care. One are the people who have a positive test, whose symptoms are improving clinically. They're more stable, but they simply need a place to convalesce until they have a negative test indicating that they are clear. So that's more of a residential setting. And then there are the ones that are kind of like a step down. They're post-acute, but they still may need some clinical care and staffing. So he's looking at opportunities for both. We've identified some hotels, some nursing homes that have been previously shuttered that could be reopened, and a whole host of different spaces. And Dr. Mill and his team have done an enormous job of not only finding spaces, but then figuring out what they would need to be converted. So that includes anything from ventilation systems itself that actually support a decreased transmission of the virus, but any of the IS, information services, monitoring, clinical setups, laboratory setups. How would we do all of these things? As well as potentially mobile units. Could be anything from respirators, ventilators, et cetera, to support. So lots of stuff in play. Still actually nailing things down, but we now know we have physical sites in each of the regions that we can convert.
Great. Thank you very much, Dr. Meadows. The next question is, how are you handling other social needs that are heightened in the crisis? For example, those with opioid, drug issues, domestic violence, homelessness, etc.
So, we are all, if we are not frontline caregivers, clinicians, we are teleworking and we are living in the virtual world with everybody else right now. And so one of the things that we talked about and recognized a little bit ago, a couple of weeks ago, was that when we started doing social distancing, people were feeling more and more isolated. And when people are faced with fear, uncertainty, scary information about this virus and disease in general, we realized also that depression, stress, anxiety, substance use, suicide intent would all be increasing. We knew this was coming our way because this is what happens when people are in crisis. We also began watching some of the data, some of the early data coming out and showing calls about domestic violence. We've been watching for child abuse as well. And so what we've done is try to do virtually the best way we know how to support and connect people with services. So social media campaigns have started and are ramping up further to connect people virtually and by phone to hotlines, 1-800 numbers, online support groups, and then connecting them not only with the ones that are within Providence itself, but connecting them with the established organizations. Like AA has online web-based counseling available, and making sure everybody knows that, right? Same thing with the National Suicide Hotline, the National Domestic Abuse websites, et cetera. And so we've been kind of not blasting, but making prominent in social media and online, how to access that. And that's to the public in general, but that same information is being shared internally amongst our own caregivers.
Thank you, Dr. Meadows. Our next question is, what has been the collaboration between all the hospitals and caregivers in greater Seattle area, and what have been the learnings?
I can't speak to detail about what have been the all of the learnings. I do know that probably the most prominent thing, particularly in the Puget Sound area, is that Swedish has formed, as well as the rest of Prov Legacy, an alliance with other hospitals who typically we would consider them competitors, but in the war against the pandemic, we are arm in arm. And so I think what they have learned is that when they speak with a common voice, particularly when going to the governor's office, the state public health, the CDC, or the federal government, it carries much more weight. They know that there are enough common things that they are concerned about that they can weigh in together. I think that has helped. In addition, they've been able to compare what their capacity is, their common challenges with test kits, masks, PPE equipment, and they can also track with each other by sharing their data where we're seeing the spikes. That is particularly important in Western Washington, but Eastern as well. And that's one example. I think that similar collaborations are occurring with our hospital and providers groups in our other regions like Oregon and California.
Great. Thank you very much. Our next question is, how did you handle, or do you handle, visiting for family, for patients, for dying patients within the hospital, not just those dying from the COVID-19, especially given the lack of PPE equipment? And the same applies for priests or religious visiting patients.
So I don't know that I can answer that specifically. I'm going to say that I know that we have some spaces in hospitals where we are not cohabitating, of course, the COVID positive patients, right? That still allow people to come in. I think, though, that our efforts to do the social distancing is probably interfering with that, right, to some extent. We're not encouraging people to come to the hospital. When someone is dying, I don't know what the exceptions are. We will have to talk with our mission leaders to find that out, how they're handling that on an individual basis. I don't know if Dougal is on the line, but that would be something that I would ask him to speak to. I know that in the nursing homes, however, we have a strict no visiting policy, and I don't think that's unique to us. So it makes it a little bit sad, and I will tell you that personally, it's a distressing experience to go through. You know, my aunt in a nursing home in New York passed away Sunday night. I could not get to her fast enough, and my cousin locally there in New York was not permitted in. So, yes. But I have to tell you something. As much as I am sad for my cousin not being able to sit with our aunt, I also know that my cousin was one of the people in the higher risk group for developing the more severe symptoms herself.
Dr. Meadows, I'm very sorry for your loss. That is, I know, in the midst of all the in all of the struggles that we're all facing, really brings it home and makes it difficult to see and feel firsthand. Our next question is, when patients are being tested to rule out infection, or once they have been tested positive, are you limiting the amount of providers that are assigned to the case? Or how do you reduce exposure? Chart review for consultation services, etc.
I would actually ask our clinical teams in the hospital to address how they are individually doing it. I am going to assume that we are only allowing in the clinicians that are absolutely needed for the care of the patients. This would not be a time for any extraneous. The other thing that we have already been talking about is for the clinicians who are handling or managing the patients who are COVID positive or strongly suspected, is we are taking a look at the risk for the actual caregivers themselves. So I don't mean to disparage my colleagues, but a lot of us are a little bit older, and a lot of us have our own underlying risk factors. So I find that the clinical teams are doing the work of looking within their own groups about who should be up front, who is needed where, and being very careful and cautious about who should be engaged. Again, it brings back in the importance of having adequate PPE and masks for that protection.
Thank you, Dr. Meadows. Providence serves a large Medicaid population. Have you needed to provide specific outreach or support for low-income patients in your communities?
That's part of the community outreach effort. The community health partners, as well as the mission leaders and our own population health teams, both at the system and local, have been reaching out to the patient populations. The initial data that I'm seeing, though, really is a mixture of people who are commercially insured, Medicare covered, more Medicare covered than Medicaid at this point. The whole focus of our outreach effort, though, is still focusing on basic prevention. If we can do the prevention more and more and more, from soap and disinfectant giveaways and handouts to help make sure they have what they need, the information itself, the really, really strong encouragement for social isolation and really explaining what that actually really means. So it's not just waving from the door. It really is 6 feet or more, right? And then also the stay at home. I have found that not just Medicaid, but that subsegment of Medicaid and the people who are completely uninsured, who are homeless, are the ones that are most exposed. That is why we took up amongst ourselves our own collections to actually, 2 to 3 weeks ago, actually collect funds and directly donate them to shelters. I think we covered 62 shelters that first week, as well as food banks, where people who are dependent on food banks for food are still coming and still congregating. We've gotten the food banks to use the donated disinfectant, soap, and hygiene products. They're giving that away with the food, but they've switched their food delivery to pre-bagged, prepackaged to minimize contact and transmission.
And Dr. Meadows, Dougal Hewitt has responded with the question about visitation for priests and ministers. Yes, we have guidelines for anointing the sick and for visitation by priests, noting the restrictive environment that Dr. Meadows prescribed. The next question is, are there specific protocols to follow for a quarantine patient before coming to a dental office or to a skilled nursing facility?
So we have been actually discouraging people from doing the routine care and services that they may normally do. And that includes dental appointments unless you are acutely in pain or acutely ill with an infection or something along those lines. So someone who is in quarantine, who is either awaiting tests or waiting for a negative test, we've actually discouraged them from going to those appointments. That includes everything from dental appointments to therapy, et cetera. We are keeping them literally quarantined away from anyone else who could possibly become a recipient of the virus itself. The folks that are actually in the hospital who can then be moved to a skilled nursing facility need a negative test in order to be able to move. And that is to protect the other residents and the healthcare providers in the facilities themselves.
Thank you, Dr. Meadows. The next question, and we'll just take 2 more because we are nearing the end of our call. Are there specific areas of care or populations that you all continue to struggle with?
I don't know struggle with. I think there are populations that I worry about. And, the best way to resolve worry is action. So that's what we're focusing on right now. I am most concerned with the populations that normally are forgotten. They do not receive the outreach that they need or in a way that they can receive it. And so I'm going to say that when I'm referring to the people who are easily forgotten or marginalized, I'm going to use broad stroke, and I'm going to talk about not only the homeless and people living in shelters and depending on food banks, but I will also tell you that I'm concerned about immigrant populations who are afraid to come forward, who are afraid to come and get information, and who may not access care because of all of the negative policies that have been put out by this administration against them. Most recently, the public charge issue, right, which basically caused people who have gone through the process of trying to receive a visa or a green card to now have second thoughts about even approaching it, particularly if they have had a past use of Medicaid, food stamps, TANF, Section 8 housing, or rental assistance. I believe they will be more reluctant to come forward to get information, to receive even donated supplies. I'm also concerned that they won't receive the information in the language and in the communication media that they will best receive. And when that happens, that leaves pockets of people who are then basically naked. They don't have the prevention that they need to prevent the virus transmission, and so those communities become greater at risk. The same can be said in a similar manner to people who are living on the street who have mental health issues, who may be isolated. To seniors who you would think, well, they're living in isolation and alone, but that means that they are more likely to be cut off from food, nutrition, and healthcare access because the volunteers who normally take care of them will not be there because of all the social isolation and the stay-at-home orders that are in place. Minority communities that typically may not get the outreach that everybody in the general population sees on a regular basis. They need extra effort, extra outreach, and into the community. We could bring the message to them in a safe way. And so that needs to be done on an ongoing basis. We have not peaked yet, so there is still much work to be done to address the needs of these populations.
Dr. Meadows, our last question follows along those same lines. Out of the total COVID cases in Washington State, there's a question of, do you know what the percentages are that are requiring hospitalization? And the second part was, is that percentage continuing to increase? And then do you have any idea how children are being affected? Are they testing positive?
Okay, so I don't have the hospitalization rates for the whole state of Washington. I know that within Providence itself, we are seeing continued steady incline in the number of cases in general that are suspected of being coronavirus. And I think we're up to, within Providence itself, 853 cases. The number of people who have confirmed through the testing itself, I think is a little over 300 at this point. Both of these numbers continue to increase. I think in New York they talk about, well, the number is doubling every 2 days. We were earlier at that rate where the number was just increasing, and coming in. You may think, well, those numbers don't sound a lot, right? It may feel like, well, a couple hundred here, a couple hundred there. Is it really a lot? But I want you to remember that these are people who are sick enough and able to come in, and these are people who we've actually had a test available to test. We believe that a large portion of our population has already been exposed to the virus. That the majority of them, if we're lucky, 80% will have mild to moderate symptoms. Unfortunately, there's another whole segment of them that may start off mild to moderate, but that can escalate even at the end of the first week of symptoms into something more severe. So that is what we're looking at, and that is our great unknown. As far as children, I don't know of any in Washington itself. I know that at one point we had at least one 5-year-old testing positive and a 12-year-old testing positive in other places within our system. But there were no deaths with the children that were in Providence care. I think the case that is making the news right now, I can't remember if that's California or not, the teenager is the first death of someone under the age of 18 in the United States.
Thank you very much, Dr. Meadows. Before we close out and I turn it back to Nadine, on behalf of the Catholic Health Association and the entire Catholic Health Ministry, we just want to extend our sincere thanks to you, Dr. Meddars, for spending so much time in the middle of this crisis and pandemic to share firsthand experience with the rest of the ministry so that we can all learn from the lessons that you all have had to wrestle with firsthand. Thank you again, and let me turn it back to Nadine.
Thank you. On behalf of the Catholic Health Association, I would like to thank you for participating in today's event. A recording of this event will be sent in an email and will also be posted on CHA's website at www.chausa.org/coronavirus. This concludes today's program. Thank you and have a great rest of your day.